Precision medicine has transformed the way we treat gastric cancer. We understand more now about what medications to use for each individual patient in combination with chemotherapy. So from that perspective, especially in patients with first line, but now even in patients with early stage surgically treated disease, having biomarker testing as early as possible, we understand how to make patients improve their chances of cure and long-term survival, even in patients with metastatic disease. And I can give specific examples. For example, microsatellite instability. Microsatellite instability leads to hypermutation and extreme response to immunotherapy. In patients with early stage cancer, in those patients, we may be able to avoid surgery altogether if there's a good response to immunotherapy with the drugs such as anti-PD-1 therapy or combined PD-1 CTLA-4 block. Other examples include anti-HER2 agents. HER2-directed therapy is important for approximately 20 to 30% of patients with gastroesophageal cancer. And in those patients, again, knowing the biomarker early will improve their outcome to not only first-line therapy using chemoimmunotherapy with anti-HER2-directed treatment, but also in subsequent therapies. And other biomarkers that are important in gastroesophageal and gastric cancer are claudin biomarker, PD-L1 biomarker, and so forth. So knowing the precision medicine and knowing the outcomes of the studies is so important for improving outcomes for each individual patient for gastric cancer. These are simple tests using protein immunohistochemistry, so they're faster to come back than mutation testing. Mutation testing usually takes 2 to 3, sometimes 4 weeks. Immunohistochemistry protein testing takes only 5 days, maybe even less, depending on if you're at a big center like ours. And all of those tests are covered by insurance. They're part of our standard guidelines. NCCN guidelines, ASCO, all of the big societies that put out guidelines for treatment of stomach cancer in the United States, but also worldwide. These biomarkers are standard and are covered by insurance. In fact, it's the opposite is true. If you don't have the biomarker testing done, some of the insurance companies won't approve some of the newer drugs because they will only approve them in certain biomarker selected precision medicine settings. Yes, the biomarkers absolutely are geared toward decision on immunotherapy, what type of immunotherapy, and what other targeted biologic therapy will be used. The good and bad thing about this disease is that chemotherapy works very well. It works, but it doesn't work for a very long period. It doesn't work for years. It works, for 1 or 2 years, and it may stop working. And so what we're doing is we're using different types of chemotherapy, combining them with immunotherapy, targeted therapy, other biologic treatments we designed in the lab based on the precision oncology, but using chemotherapy as a backbone to debulk the tumor, right, to increase the response and ultimately to help these other designer therapies, precision therapies, to carry the response, be it immune response or response to targeted therapy. Early detection is very important. In fact, as we're developing more and more targeted and vaccine possible strategies, early detection will be critical. The problem is right now there's not a reliable blood-based early detection methods. In fact, the best test still to detect a disease is to do an early endoscopy, a screening test. Endoscopies are relatively easy to do. They're not dangerous, and certainly if a patient is undergoing a colonoscopy, it's not unreasonable to look. What we find is most patients have some very vague symptoms for months before coming to their doctors. And what the community of physicians is not aware of is that this cancer is increasing in incidence. It's becoming more common in young patients, people in their 40s, people in their 50s who have no major risk factors in terms of reflux and so forth. In your community, it's not rare, and worldwide, it's a huge burden. And again, worldwide, even in the United States, what we're seeing is increase in incidence in younger patients. Some of it, I think, may be immigration patterns or just what we're doing in our environment. But worldwide, there's an increase in younger patients diagnosed with the disease. So I think as an advocate for the patients and as in general, as the guidelines are being adjusted for colon cancer. Now for colon cancer, for example, for screening, we have to do it in younger and younger populations. And if you have any symptoms, either of mild anemia or even just mild reflux or abdominal discomfort, you really should seek out and get an endoscopy, because early diagnosis allows for increased chances of cure.